goal of tonight is to provide some access to some of our leading edge practitioners who have been behind designing our baseline testing and concussion management program. As I said, my name's Randy Goodman. I'm a sports physio by nature, have been a sports physio for 25 years, have had an interest in concussion since I started working with the elite level of sport, whether it be freestyle skiing. When aerials first started, we had a few concussions at that point, and working my way into being involved in hockey at an elite level, up to the pro level. I was lucky enough a year ago. How many people have been to Fortius before? How many have never been here? Excellent. Welcome to our house. I was lucky enough a year and a half ago to be asked by the founder, Scott Cousins, and some of the senior leadership here to come and build a world-class team. So I feel like I'm almost like an all-star manager of the health, sports, and medicine and training environment. And we went across the country to find some of the best in Canada and in North America, whether it be sports medicine physicians, physios, massage chiro, dietitians, strength and conditioning people, to put a team together to become a world-class athlete development and sport and exercise medicine facility. The goal of this event is to help educate the sporting community about what's new about concussions and why there's been so much buzz in the last 5 years about concussion management and how important it is. And with the support of the Fortius Foundation, we actually have the ability to provide these events for free, which is a really good opportunity for all of us to share the knowledge that some of these people have spent, 10, 20 years of learning their trade and being able to share with you and have you ask questions at the end. This is a unique thing. This is one of the first comprehensive programs in Canada to involve baseline testing, including experts in vision and balance and cervical spine and physicians and all of that scope of management, and to put it all together in one facility. So we have all the people in one facility. It's taken about a year to put it together, but we're finally ready to roll.
Most of us have had experience with people who have had concussions. My thought about concussions is it's a team approach. And what I mean by that is it's a team of care providers, healthcare providers, but it's also a team approach in the community. As a parent, as a coach, as a referee, I think we need to provide a team support in a group environment so you don't feel isolated. And that's often what people do after they suffer a concussion. They feel quite isolated and they're confused about how things are. How many here have suffered a concussion? Just curious to know. Yes, I have too. So there's many of us who had suffered, so we kind of have walked through some of this ourselves. But our goal tonight is to present our thoughts and research around concussions, ideas about diagnosing concussions and appropriate management of concussions. And so our panel will hopefully go through little areas about concussions and their areas of expertise. What I wanted to do today is just kind of explain a little bit of basics around concussions. Concussions are the definition of concussion is a significant force, but it doesn't need to be a force to the head. It can be a force to the neck or to the body, creating an impact to the brain. Things, we see the hockey pitchers, we see that, but it doesn't necessarily need to be that. Well, all can recall the injury to Sidney Crosby that was played over several years ago. Certainly not a significant head hit, it was more of a turn, and so there's some angular force that happens. Anybody have an idea of kind of the forces that one can experience with a concussion? No. I just thought I'd show this little slide here. It kind of gives you an idea of sort of dramatic in terms of G forces that one would experience. So you're walking around, that's 1G, right? Gravity, roller coasters 4 to 5, jet fighters 9. So by measuring forces on the brain, especially with some of the helmet sensors and so on, we can experience up to 100 Gs, and even in a heavy football hit, it's up to 150 Gs. So there's a significant force that the brain feels, whether it's angular, spinning, or whether it's a direct force. The brain feels that. Then what happens is there's a functional change in the brain. And like she was explaining, that people ask to me, well, can we do a CT scan? Can we do an MRI? And a plain MRI or a plain CT scan very rarely ever shows any damage. So it's not necessarily a structural, but it's functional. The way I explain it is there are cellular changes in the brain, and the brain has obviously had an impact, and it needs oxygen. It's a crisis, and it's probably not getting enough oxygen. There's a cascade of chemicals that occur. Simply put, the brain gets into crisis, and then you display these symptoms that we get. What are kind of the symptoms we get? Well, number one, often we complain of headaches. What other symptoms would you say? Just fire away, I'm just curious. Yeah? Disorientation? Nausea? Loss of memory? Any other? Fatigue? Neck pain? Pressure in your head? Nausea? Blurred vision? Balance problems? Sensitivity to light? Sensitivity to noise? Feeling like you're in a fog? Not feeling right? Troubles concentrating? Decreased energy? What else? Confusion? Drowsiness? Emotional issues? Irritability? Mood swings? Nervousness? Sleeping? Yeah, too much sleep? Interrupted sleep? All of the sleep disturbances, certainly. So there's been an expert kind of group in the world that have come together and sort of proposed sort of an idea of symptoms and met with it and said, how can we assess concussions? And they came up with something called the SCAT-3, which is the Sport Concussion Assessment Tool. And many of you may have heard of that. There's a third version. And on that list is the symptom score. So a lot of us healthcare professionals will use that symptom score, and we score it out of 6. So 0 is no, I don't have a headache, or 6 is the worst headache I've had. So you'll score it out of 6, and you'll also consider the amount of symptoms. So if someone presents to me and says, I've got the list of symptoms, but there's 6 out of 6, that's quite severe, right? If they have all that list, which I've kind of gone through, it's quite severe. You might have somebody that presents with, no headache, maybe just a little dizziness. Probably not going to be as significant, but certainly you're going to get all these symptoms. So you're going to get drowsiness, you're going to get trouble sleeping, etc. What's the good news when you get a concussion? We know that at least 80%, up towards 90% will get better in 7 to 10 days. So that's good news. So when I see somebody, I try and make it positive. Listen, most of you will get better within 7 to 10 days. Recover, your symptoms will go away. And that's the evidence in the literature. What do we do with the 10% or the 15%? A lot of those will get better over several weeks to months, and some will be left with some residual complaints. But the most patients will get better. So number one, you have to think about the positiveness of that. What are the risks for concussions? What would predetermine risks? People ask, what would get me a concussion? Any ideas? Right, previous concussions, correct. So it's interesting to note that the literature shows it's kind of the distance from the concussion. So if I had one at the age of 15 and I have now, my risks are probably low for persistent symptoms. But if I had a concussion 6 months ago and I had another one, my risk of having a severe concussion, prolonged symptoms are going to be longer. Does that make sense to you all? So it's often the distance out from concussions. The number of concussions will make it. What else? Any other ideas? Yes, so the sport you play, right? So ballet, a little different than rugby, right? Higher risk, right? Football, bull riding, those kinds of sports, probably a little higher risk, correct? Gender, there's some controversy about gender, but there may be a slightly increased with females. Age, you're younger, you probably have a more severity in your symptoms or prolonged symptoms, potentially. And then, as mentioned, I think this is an important factor that sometimes we miss. I think if you have pre-existing mental health issues, anxiety, depression, sometimes, and this is just my experience, is that I find that sometimes the resolution of symptoms may be a little bit longer for those patients. Coping strategies. I try and kind of explain it like this. Most of us, we all have stress in our lives. We're athletic, we do activities, and a lot of us do sports activities to help our stress. That's the way we cope. I run, I relieve my stress. So here you have a high-functioning individual who deals with stress by activity, a positive way to deal with stress. They get an injury, Now you take their coping skills away from them and how they deal with stress, right? So now their coping skill of the way they deal with it is now gone, plus they have an injury. Now you're sitting them down and it cascades it. So that's often how I kind of try and explain to people what happens. So certainly that's a pre-screen to know about patients. One gets asked, well, how are we going to fix the brain? What can we do? And you know, there's research coming around on that, and this is areas everybody here today is going to talk about ways to diagnose this, maybe pick up some little areas that maybe we can address, whether that be vision or whether that be neck issues. So certainly there's a component to rest, which we all know. There was a study done recently out of Boston that showed that they took a group of athletes, took the group that that just went back to activities just right away. They took a group that had complete rest, and then they took, say, no texting and a little bit of texting, and they categorized it. What they did find is that the group that went right back to activities took a significant longer time to recover from their concussions. There was some mix in the group, so absolute rest associated with a little bit of texting, say 20 texts or less, that group probably did about the same. So the fundamental principle coming out of that study would probably be rest is important in the first few days, and then the controversy comes in how quickly do you progress your patient. But certainly rest is important, not getting right back to your activities, and especially physical and mental or cognitive. So going back to school, concentrating, that can certainly throw you back for a long recovery. So the rest of us, we're going to talk a little bit more in our group about areas of concussions, areas how to diagnose, areas that we're looking at, areas we can improve, and then and certainly a treatment. We do not want to have anything like that happen to anybody we see, and certainly it's been, concussions can be certainly lead to long-term problems, and we do not want to see that. So that's our goal tonight.
Performance vision, when we think about vision, we think about a process. We think about a process that allows us to extract meaning from our visual environment.
Better?
Better. So it's not as simple as just being able to see things clearly at distance or near. It's actually a very complex, developed, learned function that requires a number of different skills. And it's important because it allows us to make sense of our world. There are neuroscientists who believe that about up to 90% of the information that we take in that we need to perceive, to interpret the world, and to learn comes through the visual system. So you can imagine the impact that a disruption or a disorder to the visual system can have on not only your ability to function in your sport, but your ability to function at work and at school. And unfortunately, about 50% of patients who sustain a brain injury have a dysfunction within their vision or their visual cognitive system. So vision actually consists of two separate processing systems. There's a central system, which is we call it the focal system, and it's the what system. It allows you to obtain really detailed information and identify objects. The second system is the peripheral or the ambient system, and the ambient system tells you where things are in space. So it tells you where you are and where your eyes are looking. If you think of it, an analogy would be a puzzle. So your focal system will identify all the little details of the piece of the puzzle that you're looking for, so the color and the shape. The ambient system will allow you to see the whole picture, so you know where the piece of the puzzle goes. If you can see the detail well, but you can't see the whole picture, then you don't know where the piece of the puzzle goes. If you can see the whole picture, but you don't see it with detail, then you can't figure out where the parts go. So you need both systems, and you need them to work harmoniously together. The ambient system, it takes information from your peripheral retina, and it actually then matches that information with the information that's coming from your vestibular system, from your proprioceptive system, your kinesthetic system, and it allows you to figure out where you are in space. So it's spatial orientation, and it's the general information that you need for movement, for balance, for coordination, and for posture. Now, unfortunately, with head injury, the ambient system is the system that's most often affected. So to review the symptoms, Dr. Peters basically addressed all of them, but the one thing I'll say is that when we talk about the ambient system and how the ambient system integrates and communicates with the vestibular and the proprioceptive system, in brain injury, what happens is it's almost like someone turns down the volume on the ambient system, so the ambient system isn't functioning well, and that, in effect, almost turns up the volume on the central system. So when you experience movement around you, your brain senses that there's movement, but because it's now not communicating with the other senses, like your proprioception and your vestibular system, it internalizes the movement, and that's where you end up. You'll either experience dizziness and vertigo because your brain can't kind of figure out where are you moving, is the world moving, it, and it can't sort that out. The other thing is there's a big effect on things like with the ambient system, with reading comprehension and your ability to make sense of information, and we'll talk about that a little bit when we talk about eye movements. So what are some of the things that we test for at Fortius? One of them is the King-Devick Test. Maybe some of you have heard of it. I'll talk about it a little bit more in a minute, but it's a test of your eye tracking skills. Near Point of Convergence test, so that tests your ability to use your eyes as a team. Some eye movement tests, your pursuit and saccadic eye movements. Pursuit movements are those movements that allow you to track an object smoothly and accurately as it moves. And your saccadic eye movements are your ability to scan space and jump from target to target. We look at visual blur with head movements. So, if you're staring at a thumb and you move your head, can you keep the object clear? And the other thing is your motion sensitivity. So if you are keeping your head still and moving the thumb, are you able to maintain your focus? So the King-Devick Test, it's a nice test. It's a quantitative test that's been designed to measure saccadic eye movement, so basically how well you can scan, how quickly you can scan. It was originally designed to assess kids with learning disorders, in particular with reading, because reading involves a scanning movement. In fact, reading involves a pursuit movement to just follow the letters in a word and then a saccade to the next word. So if your ambient system isn't working well, your pursuits and saccades aren't functioning well, and your ability to make sense of visual information isn't working well either. The nice thing with King-Devick is it's inexpensive. Megan will show you a version of it, but you can get a paper copy that you can carry around with you. It's just like a little small booklet, and there's an online version as well. So for a coach, it's inexpensive. You can use it as a sideline test to try and determine return to play status. The thing with King-Devick, though, is there are norms. The norms were established primarily in the reading population. So you need a baseline. So basically what you want to do is, as a coach, do a baseline on your team prior to any concussive event. If the athlete has some kind of head trauma or neck trauma, you can take them to the side, you can repeat the test, you can compare it to their baseline. If you're doing the online version, it's all stored there, so you can do it from your iPad. If you're doing it manually, then you'll need to keep the scores for your players with you. But it's an easy way to kind of look and say, if their scores really deteriorated, you're going to just keep the player off the field and then seek some medical advice afterwards. And this is just an indication of what the test is. So in the first demonstration card, it just shows you, indicates to them what the scanning pattern would be. In the first test, you can see it's easier because you've got the lines to guide you. The second test is a little more difficult, and then the third card is obviously much more challenging. We measure the time that it takes to complete all 3 cards, and we do it 3 times, and then you record any errors. So pretty easy. We do the near point of convergence test. So basically, we're looking at your ability to align your eyes and use them as a team. And one of the things that happens with concussion a lot of times is that people have a really hard time converging their eyes. So we look at your ability to basically follow a target in, and we see where your two eyes break down and they can't maintain their focus on the target, their alignment. And we look at that, we do it a number of times to see, does it change with fatigue? And in particular, we look to see, does it elicit symptoms? Other tests we do, the pursuit and the saccadic movement. So again, when we talk about the pursuit movement, if you think of soccer, the pursuit movement would be the following the ball, and the saccade movement would be anticipating where the ball is going to go, scanning the field, and then seeing who can receive the pass. So both are really critical in sport, and both of them are affected with concussion, in particular when the ambient system starts to shut down. So we're just watching eye movements, how they can track a target that we give them. We look at both the horizontal and the vertical direction, and then we look at saccadic movements as well in the vertical and the horizontal direction. And so what we're looking for there is, do we elicit symptoms? Do we find that when they're trying to do that, that they feel like they're losing their focus, and that the system's breaking down? We look at visual motion sensitivity as well. So again, fixating, moving your head, does it elicit symptoms? And then we also look at where not only is the thumb is fixed, but then when they're actually moving their head, and then when they're moving their thumb. And so when do we do the testing? So usually what we'll do is, after a period of rest, at the discretion of the sports med doc or the family doctor, if the symptoms are persisting, especially if it's been 4 to 6 weeks post-concussion, and in particular if we have the baseline readings and you're not returning to your baseline readings, then we're going to do a more thorough intervention. So we will do a complete performance vision concussion assessment. Unfortunately, the test is about 2 hours long, and we often have to divide it over several visits because in severe cases, we're eliciting symptoms when we're doing the testing. So we can sometimes only get through maybe 20, 30 minutes of testing, and then we have to let them have a rest and then continue testing or have them come back. So what can we do when there are symptoms? And of course, there's the behavior modifications. So some is rest, and some is to reduce the amount of close-up work that you're doing. Sometimes it will be things like avoiding driving or avoiding being in visually busy places like malls. When I talked about how the ambient system kind of gets shut down and the central system gets cranked up a little bit, what happens in that scenario is that your central, that detailed vision, you get lots of little bits of detailed vision, but you don't have any context to put it in. So sometimes we will use lenses to actually blur the central system a little bit, just to calm it down so the ambient system can start to function again. So we're going to quiet the central system. Sometimes we use lenses to help support the focusing mechanism, which is often affected with concussion. Sometimes we use lenses to help the alignment system, which is also affected by concussion. Sometimes we use colored filters because light sensitivity is an issue, so we'll use a color filter during that period of time. We'll also do some neurovisual rehab, so that will involve exercises where we're working the ambient system, sometimes quieting down the central system, and eventually helping to integrate the systems back together. We may push to where we start to elicit symptoms, and then we back off, and then we rest, and then we start again. And a lot of times we're doing this treatment in conjunction with the other practitioners at Fortius. You'll find that if you have an issue with eye alignment, you may adopt some unusual head postures and tone to try and maintain what function you have of your eye alignment. So as we're working with the eye alignment, we will be working with other Fortius practitioners. It could be physiotherapy, massage therapy, the athletic trainers, to try and deal with the other issues at the same time, and also integrating in some vestibular rehab therapy. So on that note of integrative practitioners, I'll let Randy introduce the next speaker.
Everyone hear me okay? So when we're talking about balance, we often use the term postural stability. So what this is the ability to maintain a desired postural orientation. So for example, if you're walking down the street and someone happens to nudge you, are you able to continue walking down the street without falling over? But when we measure balance in a clinical setting or at the side of a field, we're often looking at postural steadiness. So this is a person's ability to stand as motionless as possible in quiet stance. So there's a number of systems in the body that help to regulate balance. We take in information from our eyes. We have proprioception and touch, so our awareness of where our body is in space. And our inner ear plays a big role in maintaining balance. So when a person suffers from a concussion, the integration of all of this information is disturbed. And so by measuring balance and monitoring balance after concussion, we're able to get a lot more information about whether or not a person has returned to their baseline and whether or not they're able to return to their sport. So the different balance tests that I'm going to be talking about in the next few slides are not unique to the management of concussion. These are tests that have been used extensively in the literature to study things like chronic ankle instability, stability in footwear, aging, risk of falling. So this is a bit of repetition. We know that if an athlete returns to their sport too soon after suffering from a concussion, that they do have an increased risk for recurrent injury or suffering from another concussion. And we know that if a person suffers from multiple concussions, then there's going to be a decreased speed of recovery of neurological function over time. For most people who suffer from a concussion, there are noticeable balance deficits in the 3 to 5 days after a concussion. At this time, those balance deficits appear to resolve, but what we're learning from more sophisticated ways of measuring balance is that for a lot of people, these balance deficits, the more subtle balance deficits, are actually still there and may persist much longer and even well past the point where a person has returned to their sport. So this stresses, again, the importance of baseline measurements as they relate to balance. If we have measurements of what a person's balance is like at the beginning of a season before any concussions have been anyone's had a concussion, then we have a lot better idea of when they've actually returned to their normal state of balance. So this is a test that's commonly used to measure balance. It's called the balance error scoring system. It's used in a clinical setting. It's often used at the side of the field just to see if someone's got impaired balance. It involves an examiner looking at the athlete in 3 different postures with their feet together, standing on one foot, their non-kicking leg, standing in tandem, and then repeating those tests on a block of foam. And this is all done with the eyes closed. And then the way of scoring this test is basically to score an error point every time someone moves out of position. So for example, if a person is doing a trial where they're supposed to be standing on one leg and they touch the other foot down, that's an error point. If they have their eyes closed and they have to open them to recover their balance, that's another error point. So that's how you get the balance error score. So there's a lot of benefits of a test like this. It requires really minimal equipment. It can be used at the side of the field, as I mentioned earlier, but one of the issues is that it's a bit subjective in nature. If you're looking at someone and you're trying to decide, okay, is that an error point, and they start to move their hand off their hip, do you score an error point or don't you? Does one examiner score the same way as the next person? So it's a bit more subjective in nature. So here at Fortius, we're fortunate because we do have access to force plate technology, which allows us to get a much more objective measure of balance. So this animation on the right shows a picture of our force plate and a person standing on it. That blue arrow that you see is called the ground reaction force. So this is a force acting on the body under the feet. And the point of application of that force is called the center of pressure. So as a person sways back and forth, the point at which that force is acting under their feet is going to move back and forth. And this allows us to measure the center of pressure, which is our measure of balance. So on the left-hand side, you can see an example of a healthy state of balance. So that little scribble, that's the movement of the center of pressure. So if a person has kind of a normal state of balance, that center of pressure is barely going to move at all. It's going to have a nice little scribble like you see there. On the right-hand side, you see that if a person has something that's impairing their balance, that scribble is going to get bigger and it's typically going to move around a little bit faster. So by measuring that area and measuring how fast that center pressure is moving, we have a measure of a person's postural stability. So let's see if I can make my little animation work here. Oh, there we go. So this just illustrates it a little bit better. So this is someone swaying forward and then back again. So you can see that ground reaction force is also moving forward and back. And that's what we're measuring, how far that point moves back and forth. And let's see if this one works. So this is exaggerated just so you can see. So again, if someone's losing their balance and they're swaying back and forth trying to recover their balance, that point of application of that force is going to move back and forth. So again, the greater the instability, the more that point moves back and forth. So what is a healthy state of balance? As I said, typically we're looking at someone who has a small area of that center of pressure trace, and that center pressure isn't moving around too quickly. That's kind of optimal control of balance. But what the newer research is showing is that we can also learn a lot about how that center pressure is moving. So if we look at how that center pressure moves back and forth, forward and back, if it increases in regularity compared to a person's baseline, that's actually an indication of decreased postural control. So if I'm in a healthy state of balance, I can kind of let that center pressure move around a little bit in a variable way because I have the ability to recover balance. But what the research shows is that as a person has some sort of balance deficit, they're actually going to regulate that movement in a much more regular pattern. So that can also tell us a lot about whether or not someone has actually fully recovered to their pre-concussive state. So just quickly summarizing the balance component of this concussion program. How is it different? The main difference is the fact that we have access to this force plate technology, which allows us to get more objective data and also to detect more subtle differences in balance changes. The force plates that we use are typically the type of equipment that you would find in a university setting in a research lab. It's not the type of thing that is typically available just to the general public. So the fact that we have this for this program is unique to Fortius. And lastly, just stressing again the importance of baseline data. We've done a number of tests in the lab, and if you look at a gymnast and what their center pressure traces looks like, and then you compare that to, say, a hockey player, they're going to be very different in the healthy states. So ideally, we want to have baseline data for as many athletes as possible. So when we're tracking that return to the pre-concussed state, we can compare it to that individual, not necessarily to a group of individuals. But having said that, we are going to be collecting a large number of a large amount of data, and so that group data also gives us a lot of information about normal balance in terms of center of pressure sway. So it's not to say that if someone doesn't have baseline data that we can't learn a lot from measuring their balance after they suffer from a concussion.
The most common complaints of patients who have sustained a concussion are headaches and dizziness. Now, there is also substantial evidence in the literature that a neck injury such as whiplash can also cause these symptoms, headaches and dizziness. The mechanism of injury, as Dr. Peters suggested, by which a concussion is sustained, is often a direct blow to the head or a whiplash type movement where the trunk is hit and the neck may snap backwards or a fast rotation. Well, those mechanisms of concussions can also cause neck injuries as well via the same injury. So basically our concussion patients may also be suffering from neck injuries as well. And if they're suffering from, in particular, headaches and dizziness, it's possible that the cervical spine may at least be partially contributing to those symptoms. And therefore, it's important for us to have a look at the neck. The 2012 Zurich Concussion Statement, so that's the World Congress for Concussion in Sport, for the first time came out and said physiotherapy treatment for individuals with clinical evidence of cervical spine and or vestibular dysfunction may be a benefit in the management of concussion. So, is a neck injury contributing? How do we know? There's a few things we need to look at to help determine that. First thing, we really need to ask our patients, our teammates, our colleagues, are they having any neck pain? This symptom is not commonly openly discussed by the patient, Often other symptoms, more significant symptoms, the fogginess, the sensitivity to light, the fatigue, those come up. But what may even just be a little bit of neck pain, often they just don't volunteer. So we really need to ask them if they're having any neck pain. Next, they usually will present with some kind of restriction in range of motion. Now this can be obvious, but it also can be quite subtle. So we'll ask them to turn to the right, turn to the left. They should be relatively equal, looking up, looking down. Is there any restriction or is there any pain with those movements? Now those may be things that maybe if you ask them to move their neck, they may be easily distinguishable, but oftentimes a trained eye may pick something up that you might not quite notice. The other thing we'll often look at is combined movements. We'll look up and look to the side and see if those reproduce any symptoms. Headaches. Generally, concussion-related headaches are on both sides. Neck-related headaches may be on both sides, but often may be on one side. They may be unilateral. And generally, if they're unilateral headaches, those are neck-related. Concussion headaches usually don't react that way. Symptoms may be related to neck postures and positions. So, for example, if they turn their head to the right and they feel dizzy, or they look up and they get a headache, those are most likely neck-related. Concussion symptoms don't usually act that way. Neck positions that often cause headaches usually is prolonged sitting. That's very common with patients. They'll, or with anybody with neck pain, they'll often complain of headaches. So again, if patients are patient with headaches after concussion are sustaining them just with repeated sitting, then again we have to start thinking about the neck. Also, if we're looking at a patient's symptoms in total, and a lot of the concussion symptoms are resolving, for example, the sensitivity to the light, the sensitivity to noise, vision problems, that general fogginess, if all those are getting better, but their headaches, for example, aren't improving, then again, we need to look at the neck to see if there's another cause that may be contributing to them. And finally, we do have some very good objective tests that some of the therapists here can perform to look at and diagnose cervical-related headaches. One test in particular, the cranial-cervical rotation test, is 90% accurate in determining neck-related headaches. So that's something we can do that can really help lock it down if it's a neck-related problem. So what do we do if we do see headaches or dizziness that we believe is coming from the neck? First thing, as therapists, manual therapy for the neck, particularly the upper cervical spine, is usually very helpful in helping to regain that lack of range of motion and helping to reduce headaches. Certainly stretches for the neck muscles, the upper traps, and particular strengthening exercises for the cervical spine, with particular emphasis on the cervical stabilizers. So those are our deep neck flexors. And there is, again, growing evidence that patients that have sustained concussion, they have weakness in these muscles. And in my opinion, I think it's very important to get these strengthened before return to sport, especially in collision sports, football, rugby, etc., where we know they're going to be using their head, their shoulders a lot. And for soccer, when they're heading the ball a lot, they need to have a strong neck. And finally, improvement in head and neck control. So this does tie into what Jessica was talking about with balance exercises. It also might involve what Dr. Mockler was talking about with visual exercises. But what we also do from a physiotherapy point of view is we use what's called just a head-mounted laser, and basically looking to see if a patient can determine where their head and their neck is in space. So what we'll do is we'll put the laser on top of their head and we'll get them to focus on a target looking straight ahead. And we'll ask them to close their eyes. They'll close their eyes, turn their head all the way one way and then back, trying to get that laser back to the middle of the target. And what we do is we measure the distance, kind of how far they're off from back to neutral. And in patients that have sustained concussions, it's actually quite far off. And there's some good research with this in basically normative data that you should be basically within, if you're within a certain distance of the target, you should be within, say, 7 centimeters of that center. And we'll often see, again, patients that have sustained concussions, they're quite significantly off. Now, why is that important? Now that, sorry, there's a little picture of our laser there. Why is that important? That can contribute to dizziness within a concussion. So why do we get dizzy? Now that is ultimately a input from our visual systems, our vestibular systems, our inner ear, and our proprioception. So say our neck, for example. So our joints in our neck all have little receptors in them that sense where they are in space. So if our visual system in our ear is telling us that our head's looking straight forward, but our neck's a little off, and there's a mismatch, that's something that can cause dizziness. So for treatment, we'll put that same laser back on them, and we'll get them to basically track certain targets, or we'll put O's and X's up and get them to trace these targets with the laser to help retrain that system. So there is some good research coming out in the past couple of years even. Schneider et al. Up in Calgary is doing some great research with concussion patients. And what she's found is that patients that undergo a rehabilitation program combined with cervical and vestibular rehabilitation exercises, 11 of 15 returned to play within 8 weeks of their concussion. Patients that did not go through the cervical and vestibular rehab, only 1 of 14 returned within 8 weeks. And those that control group, their rehab was education and just that graded exercise program, the traditional one. But the patients that went through the cervical and vestibular rehab did much, much better. And also Schneider did show that patients that had neck pain or headaches prior to the season were more likely to sustain a concussion within that season. So that's interesting, but that also leads us to the fact that maybe we should be seeing these patients a little bit more frequently prior to season if they're experiencing those symptoms, and maybe we can do a little better job with helping to prevent them. Finally, just one thing, and actually this wasn't even in my talk, but it's strange. This is what happened today. I had a patient that I was treating for her knee and her ankle, actually. And she went back to, she was playing this weekend, so I asked her how her ankle did, and she said, oh, it was pretty good. But she'd sustained a concussion back in the summer. So she said, yeah, my ankle was good, but actually I headed the ball and I got really, really dizzy. That was strange. It's like, have you been getting any dizziness, since the concussion? It's like, no, nothing at all. Like, no headaches, nothing. So I asked her, you've been heading the ball. Yeah, she's been playing through the summer and no symptoms. But what was different this time was that basically, she tried to flick a ball on, which basically she went up and tried to flick the ball on backwards and to the right. And she got this immediate onset of dizziness. So with no other symptoms of concussion, been playing, getting the heart rate up, heading the ball regularly, no problems. The first thing I did, I just had a little peek in her neck, and I had turn left, turn right, and surely enough, she flicked that ball on up and to the right. That's where she got her dizziness, and her neck's a little restricted to the right. So I'm seeing her tomorrow for her neck.
So I'm going to get everybody to do a quick little exercise too. If everybody can just stand up one more time. Good, and then tip over this way, good, and then a little spin about. Hit anyone. Good, and so we've all done the teapot now, and we can start talking about what concussion in kids are, some of the special considerations there. But we didn't induce any dizziness or concussion symptoms there. So first of all, in kids, there seems to be an increased rate of rate of concussions. So when we've looked at number of hours played, it seems that, for example, high school students are getting a lot more concussions compared to their counterparts who are at the college level. Furthermore, as opposed to the sort of 5 to 7 days that most people take to recover from a concussion, kids take longer. They take about 10 to 14 days on average to get better. Why is this? Well, one thing might be, just as we've heard about, that the neck plays an important role. And in kids, the strength of the neck isn't quite developed yet. And when they go through puberty and things are growing really fast, sometimes the neck isn't one of the things to sort of pick up that strength at the same speed as some of the other things. In kids, they tend to have a larger head-to-body ratio, so big head, small body, small neck, and so they're also more susceptible to these forces. The impact of body checking in leagues has also been a very sort of important topic in ice hockey, and there's been studies out of Calgary as well looking at taking away body checking from Pee Wee leagues, and it's been shown that there's a threefold decrease in concussions when there's no body checking in Pee Wee leagues. And now we're looking at the same study in bantam level. In terms of kids as well, there's an increased difficulty with diagnosis. One of the tough things is in supervising these kids, a lot of times it's a lot of volunteers, a lot of parents and coaches and people who are not formally educated, haven't come to sessions like this, might not be so aware about concussions. And they're being asked to sort of police things on the field there. I had a patient today who's had a child with a concussion and said there was another player last weekend who was a goalie and had been dizzy the whole game. And nobody did anything about it. Nobody sort of pulled them off, sort of thought, well, maybe they had a concussion or something like that. The other thing is underreporting. Kids don't really know what's necessarily going on. They don't want to be targeted out. They don't want to be different. They all want to fit in. They might be scared of repercussions if they sort of report, oh, I'm having these symptoms. So some studies have looked at kids. They found kids have symptoms of concussion, but only about 50% of them were actually reporting these symptoms. So a big thing is just knowing that these kids might be having symptoms and not saying anything about it. The other thing is with diagnosis, we do have special tests that are targeted just for kids. So we heard a little bit about the SCAT3, which is a very commonly used tool. There's also something called the Child SCAT3, which is meant for kids between the age of 5 to 12 years, and it just involves parents a little bit more, has a few changes to those questions as well. The other thing that I think is important is looking at baseline considerations. And we've heard a lot about these things already. There are a number of different things that can be picked up at baseline that can increase either your risk of concussion, so things we've talked about already, history of a concussion before, migraine headaches isn't anything I don't think we've mentioned before, but neck pain, dizziness. But also there are things that can make that if you have a concussion that they're going to be a lot worse. So we've heard about anxiety, depression, but also other things like ADHD, learning disabilities, dyslexia, and if at the time of the concussion you had a loss of consciousness, nausea, or vomiting, those concussions can persist, those symptoms can last a lot longer. At the time of injury, what are some things to sort of consider in kids? Well, first of all, make sure there's somebody there can get them off the field. Have them at the sideline, have a chat with them, see if they're having any of these symptoms. Keeping in mind that sometimes with concussions, the symptoms aren't happening right away. There can be a delayed onset of these symptoms. One phrase that's sort of been thrown around and tried to get ingrained in people's minds and in kids' minds and coaches is, when in doubt, sit them out. So if they've had a mechanism, you're not really sure, did they or didn't they, just sit them out. There is something called second impact syndrome. Fortunately, it's a very, very rare occurrence, but it seems to be that the people who get this second impact syndrome are usually kids. Basically, it's that if you have an injury again before your concussion is sort of healed, then it can result in some very serious brain swelling and has a mortality rate associated with it too. Again, very rare, but seems that kids are more susceptible to that. The other thing a lot of parents ask me about is the role of imaging and CT scans and MRIs and so on. And they have a very limited role in concussions. It's more a lot about your symptoms and the physical exam findings. I think as a pediatrician, I always like to remind parents that CT scans aren't without their own risks. They deliver a lot of radiation, and especially in a child, in a growing child, that radiation is not as insignificant as it might be for an adult. And so we like to use those CT scans only when there are certain red flags that we see in the patient. Finally, I wanted to talk about considerations for management. So in kids, most of them are going to school. They have a lot of responsibilities at school. And cognitive rest is as important as some of these return to play things that we're going to talk about later. Cognitive rest means not only no school, but also no reading, no TV, no iPad, no texting, none of that fun stuff that kids like to get away with and do. And so educating the kids that this is really important, particularly for the first 24 to 48 hours, is important. I like to talk to parents a lot about return to learning as well. Oftentimes this means that we're away from school for a few days and then coming back into the school, sometimes with partial days, sometimes with extra time given for tests or homework and so on, and making sure that the teachers are well aware of sort of the necessity of doing that. So return to learning is as important as return to play. The return to play progression that we follow here is based on the Zurich consensus guidelines that you've heard a little bit about before, and just stress the importance of having at least 24 hours between each step, and there's 6 steps, before you move on to the next level. So it means that kids really, if they've had a concussion, in the best case scenario, it's 7 or 8 days before they're back on field, returning to a full game. Fortunately, the long-term consequences are pretty good. Most of the kids recover without any difficulties or residual problems at all. But I think following this approach is sort of the safest way to make sure that there are no long-term consequences.
A tool that Randy just alluded to that we developed, the impetus really was originally the repeated calls I would get in my office from parents initially saying, my kid had a substantial hit to the head. I took them to the emergency department or my GP, and he said, oh, he's had a bonk to the head, go home, he'll be fine in a couple of days. The responsibility is really on everyone for the recognition, diagnosis, and treatment of concussion. From the player themselves, as Tommy alluded to, kids have to understand if they're not feeling right, tell someone. You don't have to be a hero. It's the responsibility of the parents. They have to stop pushing their kids and listen to their kids and not try to make them the next Sidney Crosby or Christine Sinclair. I've heard horror stories I've seen horror stories where a kid at the ice rink significantly hit his head. He could not stand. He was pulled off, throwing up on the bench, and the father ran to the coach and said, put him back out there. There's a scout in the stands. I want him back on the ice rink. I mean, and I've heard coaches say, it's not my responsibility to look at the safety of that player. I'm out here to put out a winning team. So we really wanted to shift knowledge, attitudes, and practices amongst these various audiences. We started with we coined it. We went through this exercise to come up with a name. So we came up with the CAT, which is synonymous to the SCAT3 that was alluded to earlier. So it's the Concussion Awareness Training Tool. And initially, we built it with funding from BC Children's Hospital Foundation and Child Health BC for health practitioners, because we really wanted to standardize practice in our province and throughout Canada for that matter. So this is what we came up with for the CAT. It's broken down into the learn component for physicians, the assessment component, which is the online SCAT3 that physicians can pull up in their GP in their offices, fill in a bunch of buttons, and then print out the results for their patients and for themselves, and a resources section, which I'll get into in a minute. So basically, we conducted focus groups initially to see how best to develop this tool. For the health practitioners tool, we built in CME, continuing medical education credits for it, so that physicians could get something for taking it. We wanted it to be quick and easy accessible to guidelines in a clinical setting. It's built on the Zurich guidelines, which is really considered to be the gold standard. Additional clinical resources about concussions, links to other web-based resources, printable resources for patient, and FAQ. We wanted it to be a one-stop shop. If you Google concussion, you'll get millions of hits. How do you know what's the best credible information out there? So we've really sifted through all the information and put it together on the tool. We developed it with a multi-sensory component because we learned through focus groups that some like to read, some like to listen, some like to watch. So it's built based on that. It's culturally appropriate for Canadians. It has interviews with Canadian experts such as Dr. Taunton here in the audience, and it meets the standards of continuing medical education. So this is the learning tool broken down into subsections here for physicians. It's a 37-minute course for physicians, and we built it such that if they've got shorter chunks of time, they can watch it for, say, 10 minutes, leave, and come back and pick up where they've left off. Because physicians said, it's valuable to have this stuff, but I don't have the time. It'll go on my to-do list. My to-do list is about 20 pages long. So that's how we built it for them. Again, as mentioned, it's got both the child and adult SCAT. It's got the clinical resources broken down by clinical, patient, journal articles, related websites, additional resources, case studies, videos, and expert commentary. This is an example of the case study, which I'm going through really quickly in the interest of time. It's got videos that we feel are very poignant and relevant to the learning, as well as the expert talks by Dr. Jack Taunton and Dr. Charles Tatter, renowned neurosurgeon from back east. We've also added the cranial nerve evaluation for concussed patients, so physicians can watch short segments on how to do these assessments in office. Frequently asked questions. And as of, I believe, September 1st, the site had received 26,000 hits from around the world, which is fantastic, and that's exactly what we were hoping for. So we were very pleased to see that. When we developed it, we sent it out for review by the BC Concussion Advisory Network, which is a provincial network that I'll speak about really quickly in a minute. The National Concussion Education and Awareness Committee, chaired by Dr. Charles Tatter from back east, as well as non-injury health practitioners. We wanted their feedback. We compiled all the feedback and updated the website accordingly. Now everyone wants to know, is it a waste of time or is it really having an impact? So we evaluated this as well to look at changes in knowledge, attitudes, and practices amongst health practitioners. And what we found that it had a positive effect in changes in practices amongst physicians, and that's really what we wanted. We wanted physicians to change the way they practiced in a clinical setting. It also had a positive effect for nurses as well in how they practiced as well. So that's exactly what we wanted to see, a change in the way that care was being given in our province. So now, as of about a month and a half ago, well, about a year back again, when we were developing the first CAT, I kept getting calls from in my office from parents saying, well, how come I didn't know? Nobody told me. Where do I go? What do I do? Where are the resources? So we thought there's really a need now to develop a tool for parents, players, and coaches. This was, we just released it last month. And again, it's a course for parents and coaches. For players, we didn't feel they needed a course, and not wanting to reinvent the wheel, so we sifted through all the resources and put credible short snippet videos that are already available, and I'll take you through that really quickly. So parents are central to the management of their child's concussion recovery, responsible for monitoring their child on a day-to-day basis, and responsible for seeking medical attention and ensuring that their child follows the recommended treatment. So parents need to know what to do and how to do it. The players need to understand what a concussion is and how it occurs. They need to understand what the symptoms are and the importance of acknowledging a potential concussion and telling someone about it. Coaches, and this is targeted primarily to the volunteer coaches. At the higher level, elite coaches have to go through the Coaching Association of Canada. But in minor associations, the volunteer coach is really the parent, but has to look at it from a different perspective. So they need to know the principles of concussion management, need to identify high-risk activities, to compile pre-participation information from their players, and need to know how to take appropriate action when a player sustains an injury that could cause a concussion. So on the tool, there's the coach for both. There's the learning tool for both the coaches and the parents. We've got the red flag section as well as FAQ sections. For the players, we've got these short segment videos that are fantastic for kids to learn. And we've developed, again, we've sifted through and organized all the resources, but we've also developed a couple of tools. The concussion response tool, which is accessible on iPads and iPhones and smartphones. So should a concussion occur, you can pull this up on your smartphone and record all the needed information and then have that printed or emailed to your physician or to the parents. As well as modifying the return to play tool. A lot of times parents didn't quite understand what that meant. So we kind of organized it to show what needs to be done and what you need to do. There was a bit of discrepancy about regressing back to the previous step and then how long to wait. So we've really gone and redefined it for the parents. Again, we're evaluating this tool. We're currently in the evaluation, but we want to show that it's really making a difference and we're not wasting our time and resources. This tool has been funded by the Ministry of Health, so the evaluation should be done by the end of the year. And then the third tool, which will be out in the spring of next year, is for educators. As Tommy mentioned, it's really important for the educators to know how to reintegrate the child back into the school system, what they need to do, and how they need to do it. So that tool will be ready, and then the full suite will be available all on CAT Online. I also want to briefly mention the BC Concussion Advisory Network. We established it in 2010 to bring together all the individuals working in this area so that we're not working in silos. The biggest frustration was A did not know what B was doing, B did not know what C was doing, and we were wasting resources, and how could we work together collectively? When we formed this group, I was hoping to get half a dozen members. We now sit at 65 members from educators, government, NGOs, sport governing bodies, teachers. So we're very proud of this committee. It's really to raise awareness and increase the understanding of the invisible epidemic of concussions and increase communication, which fosters partnerships, collaboration, and helps to further concussion prevention, recognition, and treatment and management. Again, the mandate is to share information and work collaboratively, and to inform, advise, and make recommendations regarding concussion. I won't get into all the objectives, but again, I mean, to identify priorities, to communicate, and to work strategically in a collaborative manner so that we can all work together and not work in silos. I mentioned the membership. Again, we sit at 65 plus from various organizations, and we meet twice a year, held through face-to-face or teleconferences. We exchange e-newsletters, and we have information sharing. We now have a Twitter account at BC Concussion that I'm still learning this whole Twitter world, but it's picking up steam, and Wilson's fabulous at updating it when we get new information. And we've got 11 national members as well, so it's growing nicely. So again, thank you to the funders, Child Health BC, BC Children's Hospital Foundation, and the Ministry of Health for all their money to put this together. Thanks.
Baseline testing that we do here at Fortius. So the whole assessment is about an hour and a half per athlete. You can come in as an individual. It's $150. If you have a group or a team of 10 or more, the cost is down to $75. The screening is designed for athletes 10 years and older. Just younger athletes require more attention because they're still in those developing stages. So our program consists of, first and foremost, our intake concussion questionnaire designed by us here at Fortius. That includes things like demographics, their medical history, their concussion history, and their injury history. And then also part of our intake is a behavioral questionnaire as well. All that is done prior to the assessment, and then we review it prior to the athlete coming in. Also included is a SCAT-3 baseline test, a cognogram, which is a online tool looking at cognitive function. So it's about 15-minute assessment done on the computer that looks at reaction time and your memory. As Mike mentioned, a cervical spine range of motion and proprioception assessment. Balance testing in the lab with Jessica on the force plates. A vision assessment looking at your eye tracking abilities, your near point convergence abilities, as well as your visuocular motor abilities, and seeing if anything elicits any symptoms. And then lastly is the stick test for reaction time. So that's basically a meter stick with a puck on the end. Randy's holding it up there. It kind of looks looks pretty funny, yeah. But it's actually pretty validated, that test. So typically, you want to do a baseline assessment prior to a sporting season. When a concussion occurs in season, we're then able to compare the baseline to the post-injury results. It's important to note that each concussion is unique, and we have to treat each person, each athlete, on a case-by-case basis. Comparing baseline scores of an individual to post-concussion scores of an individual is best practice, and I'll just kind of reiterate that in the next slide here. So this is a study done by Cognogram, but I like the graphs in this slide here. So they compared two different methods. So they looked at post-injury performance compared with a pre-injury baseline test, and then they also looked at post-injury performance compared with normative data. So if you didn't have a baseline test, you would be compared to normative data. So basically the baseline comparison method was found to be more sensitive than the normative method, which suggests that this is the more precise approach that we have to take, we should take. So just on the left-hand side here, it's comparing an athlete to the normative data. So it may appear, just the gray there is considered normal. It may appear that the athlete is within normal range, whereas on the right-hand side, tracking an athlete over time, you can actually see that there's some significant changes, and so it's important to consider that. So I like that graph because it really demonstrates that. Okay. This is just a bit of an overlay of our program here. So our program was built to establish a common evidence-based screening tool for athletes. So first, an athlete would come in for a baseline screening test, and then all of the data would be held here at Fortius in our database. The athlete would return to sport and say they sustained a concussion. They would contact us. We would then connect them with a sport med physician here. And then from there, we would review their baseline, review their injury history, and kind of formulate a best plan of action for that athlete. So whether that might be treatment, physio, sport vision assessments, and more balance testing, or return to play management with Vince. And then from there, once they've completed that return to play process, they would then be cleared by our sport med physician. They would redo a baseline to compare pre and post treatment, pre and post return to play, and ultimately return to sport. And in doing all this, we're hoping to gather lots of information on best ways to approach this, and definitely gonna learn from this. And in saying that, next would be Vince Lynn.
Once an individual sustains a concussion, step-by-step process is probably the best way we can help them to get back onto their sporting events. So the step-by-step process is best conducted through, again, as we've mentioned before, through a team process. This is with a healthcare professional to monitor the individual's progress, and if need be, to adjust their activities to make sure if they're moving too fast or they're moving too slow, we can adjust it accordingly. Each step that this individual must take should at least be a minimum of 24 hours, and before we can actually move them to the next step. So you may have seen this before with Shalina, is there's 6 steps in regards to return to play. So first thing is once an individual has a concussion, it's absolute rest. Step 2, we would start introducing light aerobic exercises, about a 70% of their maximum heart rate. Step 3, we would then look at sport-specific exercises, and then we would get into about 80% of their maximum heart rate, then leading up to step 4, which is non-contact drills. Now, once we get the individual past this point, we would have to have them clear it with our medical doctors just to make sure they're ready for the next step, which is step 5 at the full contact practice, eventually leading to step 6, which is normally back to their normal activities. Considerations that we must keep in mind is an individual must not return to play, and at least with any of the symptoms that they have start coming back. Again, with that, you would end up risking further injuries or even prolonged recovery time. Each step can take at least days, or in the worst case scenario, it could take weeks. Again, this also depends on the severity of the injury that the athlete has sustained. And again, these guidelines, as again mentioned before, are for individuals from a minimum age of 10 onwards. If an athlete is younger, we would tend to be taking a more conservative approach. More considerations is that, again, 80% of the concussions that people sustain will tend to heal within roughly 2 weeks. So there are going to be some concussions that will take longer. So if need be, we may need to involve a little bit of manual therapy, which includes chiro, massage therapy, or even physiotherapy. Cognitive recovery is also just as important as the physical side. So as Tommy mentioned before, limiting school activities, texting, school activities, even things as texting and even watching TV. So with further to the manual therapy side of it, if cost is always a big factor with a lot of parents, this was brought up to me by Randy just last week, where there's a program offered by Industrial Alliance. You can see all that through kidsplus.ca, where they have a list of benefits that you can get with a very small fee of about $32 a year, and that includes a whole list of different types of therapies. And the big thing is they cover up to $800 in manual therapy. So something to consider, and there's quite a bit of extra stuff that they do cover: dental, eyewear, even counseling if need be. And that's it.
Taking someone's head off, that's a great hit, that kind of thing. I think that needs to change. I think that's, certainly we have to empathize with that could be your kid. So that business, I've seen it, we've all seen it. I think that needs to stop, and I think as we get in majority, we just say that has to stop in this kind of sport. Encouraging, healthy activity, but not running and taking someone's head off that's what I think would help as well.
I would suggest it's experimental, but some people have had some really good success with it, and it, like Reg said, it sort of ties into the trauma of it. And there are all sorts of different approaches that will be applied based on what we find. Some people get really good relief from relaxation therapy because of their anxiety, and other people get benefits from various, and so it's about diagnosing what the challenges are you have when you have the concussion and trying to put you in the right place at the right time.
Yeah, definitely it's super important that the day of the baseline test, we recommend the athletes come well rested, good sleep, because it will and can change the results of the screen. So we're really careful to relay that message to them when we're communicating with them. And then in terms of doing a screen every year, during that 11 to 17 phase, there are changes that can happen during that time as well. And we just want to be consistent that it's done once a year so that we can monitor every change that happens, so that if someone did sustain a concussion, we're able to compare them to the most recent time that we can, instead of 10 years back, for example.
Challenging for you as a member of a team to sit yourself up and say, no, I feel something, maybe I shouldn't go. And that's where, as a leader, as a coach, you have to say, even if they're not complaining anything, we all know sometimes they won't. It's just, if you've seen the hit, it didn't look good, they've got their head down the bench, no, I'm fine, you have to sit them on.
One of the things, again, being involved a lot with that level of minor hockey, generally if you sit a kid out, you just say, okay, skip a shift, skip a couple, let's just see how you are at the end of the period. They will show something, especially if you end up doing some of the SCAT testing. So what you can do is go online and learn that SCAT testing, and it's a real easy way. Kids can't fake it for long, and then they'll tell you for sure loss of consciousness, where you see someone get rocked and they're lying down and not moving, and even if they come back and say they feel perfect, which I have had happen, they don't play. You need to get them evaluated, because if they've lost that cognitive function even for a second, that's a pretty good sign.
And I can respond to that. At our last Zurich meeting in 2012, that was one of the key identified situations, that return to learn should definitely come before learn to play. I mean, the child's academic and schooling should come well before returning to any sporting activity.